psychiatry is ever more taking on a neuroscience-based lens, a neurocircuitry-based lens, which is where a lot of neurology is, right? Psychiatry is kind of entering into what I call psychiatry 3.0, right? This idea that it's really at this level, the circuit, that we're thinking about it. And that's really where the neurologists and neurosurgeons are at.
You have found the Thinking Mind podcast.
Welcome back to the Thinking Minds podcast. Today it's Alex, and I'm very pleased to be bringing you today's conversation with Dr. Nolan Williams. Dr. Williams is a professor of psychiatry at Stanford. He's the director of the Stanford Brain Stimulation Lab. He's triple certified as a psychiatrist, neurologist, and he's also certified in brain stimulation. Today we talk about a specific treatment that was pioneered at Dr. Williams' lab, which is the Stanford neuromodulation therapy, which is a form of intensive magnetic stimulation designed to treat treatment-resistant depression. So we talk about some of Dr. Williams' findings when using this treatment and specific brain changes that he's seen in patients who have undergone this treatment. In addition, we have a wide-ranging conversation about many topics, including the differences between neurology and psychiatry and the different approaches those specialties take. We talk about the psychiatric symptoms of scurvy, the first randomized trial in medicine, the problem with the chemical imbalance theory of depression, the future of psychiatry, the suppression of psychedelics research, and we also talk about specific psychedelics, including psilocybin, and the effect psilocybin might be having on the brain. We talk a bit about ketamine, and we also talk about a lesser-known psychedelic called ibogaine, which Dr. Williams is studying on a trial that's also involving US military veterans. This is the Thinking Mind podcast, a podcast all about psychiatry, psychotherapy, psychology, self-development, and much more. If you'd like to support the podcast, check out the Buy Me a Coffee link in the description. And now here's today's conversation with Dr. Nolan Williams. Okay, welcome back. With this week's podcast, we're here with Dr. Nolan Williams. Dr. Williams, thank you so much for joining me today.
Yeah, thanks for having me. It's exciting to be on the podcast. Yeah.
What I've noticed, you're the second clinician from Stanford that we've had on. We had your colleague, Dr. David Spiegel, on.
Oh, great.
And it's really interesting to note, even nowadays, where there's so much communication and everyone feels so connected, really interesting areas of knowledge can still be siloed within institutions. And what I've noticed is, from what I've seen online, is Stanford has so much to offer. So there's a lot that I want to cover based on the work that you're doing.
Right.
But one thing I'm curious about, a big difference between the US and the UK is in the UK, we tend to have people who either train as psychiatrists or as neurologists. And it's quite common in the US for people to be dual trained. You are triple certified, as far as I'm aware. And one thing I'm curious about is what's the advantage of training in neurology and psychiatry, and what's kind of the difference between those two?
I think the value is if you're dual trained and you're trying to work in a space that requires, that or is really optimized for the kind of multiple perspectives, that's quite useful, right? So if I have a perspective, of how rapid acting interventions in neurology work and how that works within the hospital, and then I have a sense of how the psychiatry hospital works, and where you could kind of roll out and employ such a technology, then that's useful because you kind of understand both systems. It's not to say that a neurologist couldn't understand the psychiatric system. It's not to say the psychiatrist couldn't understand the kind of neurological innovations, but to live it, to be trained in it, to be that type of doctor in both circumstances helps you, I think, to really kind of intuit a little bit about how to do it. And that's kind of, I think, been part of what I've been really thinking about, is how to intuit those things,
What do you think are the key differences between the neurological perspective and the psychiatric perspective? Because to a layperson might say, they both seem to involve the brain. But what are the differences here?
Yeah, I think it's a historical thing at a level, right? I think that what happens is, things are in the psychiatry bucket, and then history keeps, keeps progressing, and then we keep figuring out there's a fundamental underlying neurophysiology, neuropathology to something, So if you look at the Salpêtrière in France, famous hospital that a lot of European psychiatrists and neurologists trained at, there was a clear transition from that kind of neuropsychiatry hospital out to a neurological diagnosis over time, right? So we used to think Tourette was a psychiatric problem that had its roots in psychodynamic kind of Freudian origins. And we know that's not true now. We know that that's like not at all what Tourette is, right? And so there's probably a time in 100 years in the future or something where you could imagine these disciplines getting back together, because psychiatry is ever more taking on a neuroscience based lens, a neurocircuitry based lens, which is where a lot of neurology is, right? So I always say that psychiatry is kind of entering into what I call psychiatry 3.0, right? This idea that it's really at this level, the circuit, that we're thinking about it. And that's really where the neurologists and neurosurgeons are at, and in that sense, it's not very different, right? It's just the type of circuit manifestations that you're talking about, where psychiatry is, more heavily weighted towards certain circuits that have to do with behavior and emotion, and neurology is more weighted towards certain circuits that have to do with more basic processes of the motor systems, and say vision and things like that. But there are there's a lot of overlap, right? There are a lot of emotional and cognitive and behavioral problems that manifest from Parkinson's and Alzheimer's disease and Tourette syndrome and all these things that neurologists classically treat. And there are motor manifestations of psychiatric illness, like psychomotor retardation or catatonia and depression and schizophrenia. So there's not really, if you're really honest with yourself about it, there's not really a good line in the sand that says over here is neurology and over here is psychiatry. It's more of, if you had to explain it, it would be more like, we understand this group of diagnoses and we have a disease model for this group of diagnoses, and therefore they're neurological. And we have descriptions of these diagnoses, but not really a disease model or a pathophysiology, and we call those psychiatric. That's probably the best line in the sand, if there was a line. But it's hard. I mean, it's hard to have have a clear description, because it would be hard to have left heart cardiologists and right heart cardiologists, right? It would be hard to think about, the left kidney is the left nephrologist and the right nephrologist. And that's kind of what we do, with neurology and psychiatry. And so it's just it's because they're so interrelated, it's kind of hard to kind of disentangle them, if that makes sense.
Yeah, there are conditions which clearly fall into the psychiatric realm, conditions which clearly fall into the neurological realm, but then there's so much overlap in between. And to some extent, where we draw that line is arbitrary. And I think in many disciplines, people are starting to realize the drawbacks of having knowledge sequestered into these different sections. And I think there's more of an encouragement of how do we bypass those arbitrary distinctions. If I'm not mistaken, you got into psychiatry and neurology via brain stimulation first, is that right?
Yeah, that's right. Yeah, and that made me honest, right? Because I wanted to be a brain stimulation doctor first, and then I kind of asked the question of what of the existing specialties where I would best be served training. I went into psychiatry and I said, well, this is great. Like, I love these diseases. I love working on this, but the conceptualization of this felt like it was kind of in process of being developed, right? It wasn't like a complete understanding. And we don't have a complete understanding of anything in medicine, really, right? Like there's all maybe broken bones or something. There's always something to learn,
There's a lot of
and
mystery.
yeah, there's still a lot of mystery. I mean, I don't even know if broken bones is fair. There was a New England Journal paper where they did sham knee replacement surgery or real knee replacement surgery, and the folks did the same. So it's like there's so much mystery left, right, in all of this. But with psychiatry, it's the biggest mystery, right? Like we know so little about what any of that actually is. The thing that the kind of historical information that I've been most encouraged by and it's been most instructive to me is kind of the history around scurvy. I don't know if you've studied this much, but I've been reading a lot about scurvy as a conceptual model, right? So what's interesting about scurvy is humans dealt with scurvy for as long as we did long distance boat trips, right? Sailors would go for extended periods of time, and they, as you know, they didn't have fruit in the boat, right? And so they at least that wasn't a consistent game plan. It was much more like, let's have like dried meat or whatever, something that could be preserved for a long distance trip from Europe to the US, to different areas that took a long time to get to. And what's interesting is there's a whole behavioral aspect to scurvy that people aren't as familiar with. A lot of psychiatric symptoms that arise from scurvy. And, at some point, some really observant sailors figured out that the folks that were eating a lot of fruit didn't develop scurvy, right?
What were the psychiatric symptoms?
They had a lot of like depersonalization, derealization sort of symptoms. Some folks sounded like they got pretty paranoid at times, the poor concentration, kind of delirious sounding. I mean, that kind of range of symptoms, right? And so you've got these folks who, experience this. It's very bad, in addition to all like the teeth and bone loss and gum loss and all these things that we think about when we train in medical school about what scurvy did. But when you put it into this historical context, what's really interesting is a lot of the sailors would come back and say, I think maybe it's eating these fruit, but they didn't know why. They had no idea what was in there. It was another, several hundred years before we synthesized vitamin C, and folks got, a Nobel Prize for that, right? But for hundreds of years, there was this question. The sailors kind of figured it out. They went to the Royal Societies. The Royal Societies had their own ideas about what scurvy was, about humors in the body and all of these things, and they dismissed it, right? And then there was one doctor who was actually the person that did the first randomized trial for anything in medicine, right? Gave some sailors fruit, some sailors like various things that are supposed to affect their humors, and I think they bled some of them. It was like 6 different conditions, but the folks that got the fruit after a week were helping the other 5 groups, right? And the other 5 groups were still quite sick. But then, that whole study was published, and it was kind of laughed out of the various royal societies, and it was another 100 years before this idea of eating fruit and treating scurvy was the answer. But I think that's what happens a lot of times in medicine. I think that we end up getting into this idea that we need to come up with our own theories about things. Folks aren't very pragmatic about things, and then we end up, progress ends up getting stifled at times, and I think in psychiatry in particular, there's a lot of that, right? Where we end up coming up with these theories about what it is, and the good example right now is this whole thing that's going on with the chemical imbalance statement, right? All these psychiatric illnesses are kind of chemical imbalances, right? And we operated off of that theory for going on 30, 40, 50 years, right? And it doesn't look like that's the answer. It looks like this idea of brain circuitry may be the answer.
A network-based
network-based idea, but we still have this kind of carryover from this chemical imbalance story. And it's been very hard for psychiatry to get onto this next era of brain stimulation, or this next era of circuit-based therapeutics, brain stimulation being one of them, maybe psychedelics as an effect on brain circuitry being another one, but really centering in on the brain anatomy. And I think it's because of the same thing that happened with scurvy, right? Where the various, folks that are entrenched with certain types of ideas propagate those ideas too long, and we get stuck in certain constructs that don't really work that well.
And not only do we get stuck in ideas which don't work, but new ideas seem laughable and ridiculous, even though they're ultimately proved correct. Like medicine, the history of medicine is so interesting because it's riddled with examples of people coming up with the right idea. If I remember correctly, even the person who first thought that we should wash our hands before having contact with patients when, for example, helping women with childbirth, the name escapes me, but even for him to get that idea accepted by the medical convention was so long and so arduous. And one thing I worry about within medicine is, I think in modern society, medicine is increasingly populated by quite conservative minded people who, by their temperament, are inherently less likely to accept new ideas. And this is something I talked a little bit about with David Spiegel regarding hypnosis, where an idea, if it has the glimmering of unconventionality, is very easy to dismiss, even
Yep.
sometimes when it has a solid evidence base. So that's, I think, something that the medical community is still trying to grapple with to a large degree.
Oh yeah, absolutely. I mean, I'd say that this scurvy example is a good historical kind of vignette of exactly what you're saying. And that's exactly the point that I was, so I think we're on the same page of that, which is, there are a lot of conservative people seemingly get more conservative over time. They get kind of locked into their patterns. Our brains seem to kind of get locked into a more conservative mindset over time because we end up getting into this view that we worked so hard to get to this point, and we want things to kind of stay the same when we get to that point, right? I think
We're
that
invested in it. And
yeah, we're vested in it, right? And so, this idea that it takes longer and it's really kind of bad for patients when we're not pushing other ideas and other kind of vantage points out there and really trying to explore them. And I think that we've held on, not just psychiatry, but I think medicine in general, we've held on to ideas too long, scurvy being a great first clear historical example of that, with a humorous thing and all of that. But there's a lot of stuff like that we've just kind of held on to too long. And I think kind of moving into a new construct for psychiatry is going to be super important, because then, we can really accelerate what we understand about brain circuitry. I mean, there's a very clear kind of first set of steps towards a circuit-based psychiatry world where, eventually, you may not do behavioral phenotyping of people through various symptom lists, and you really may just look at brain circuits as the primary diagnostic game plan. But to get there, the whole field has to kind of fully engage in that idea. And I think that, in 2023, it's happening, right? The American Psychiatric Association this year has created a neuromodulation caucus. There's, they're giving Mark George, one of my mentors who developed the original RTMS approach, an award for like the Lifetime Psychiatric Achievement Award for the APA. And I think that there's like a tilt now to do it. But, for decades, this was really out there, right?
And to be fair, I guess, to be fair to clinicians who are, have careers and trying to figure out what works, there are many more wrong ideas than there are right ideas. So it is inherently difficult. Like, success is a very narrow road. And it's easy to look back in retrospect and identify what was correct, but there's so many ways to get an answer wrong, and only a couple of ways usually to get an answer correct.
Yeah, I mean, I think that's true for brain stimulation. It's interesting. I would disagree with the way things have rolled out with psychedelics, right?
Hmm.
Because we kind of
Hmm.
had really clear, at least in, in that time period's evidence-based, really clear evidence from the standpoint of the studies that they were doing at that in that era to
In the
suggest,
50s and 60s.
yeah, yeah. And then there was like a wholesale rejection. And then there was really, it was really not much embrace of this in the
Yeah.
2000s and the early 2010s. I was at the first psychedelic science conference in 2013, and I didn't talk about it. I was in residency still. I didn't talk about that. I didn't tell anybody I went, right? Because people would have thought that was really weird for me to be
Hmm.
going to do that,
I
and
went to a convention called the Breaking Convention in
yeah,
London in 2016 in my first year of residency, and it was a very interesting mix of, I would say, one third clinicians, one third academics, one third hippies, and there was some feeling like I was doing something wrong by going to
yeah,
this
yeah,
convention. This feeling of
yeah,
just doing something illicit.
yeah, totally. No, I think I think you're spot on. Yeah, and it was that was the vibe, right? And basically, and I don't know how it was for you, but for me, I felt like none of that was taught, right? Psychedelics were listed as drugs of abuse, which I don't even, for certain psychedelics, I don't even think that's in any way realistic. Like, for instance, Ibogaine, it's just like not a drug of abuse, right? And so, that to me is the problem is it's that same idea, right? Of we kind of conceptualize things and put them into buckets. Everybody kind of is on board with that conceptualization, that it kind of aligns with the message, the kind of society's message or whatever, and then things get dismissed, and then for however long, 50 years or whatever, we didn't have the benefit of these substances that clearly seem to be helpful for people with various mental illnesses. It looks like MDMA will probably get approved by the FDA, and so it's one of these things where yeah, I think you're right. For brainstem, it really is a future forward looking thing, and it's hard to know, and you can argue that people should have been skeptical about that. I think part of that, unfortunately, is because neurology and psychiatry are separate, and if they were back together, I think it wouldn't be as skeptical, because people would have a neurocircuitry sense of things. But in the case of psychedelics, I think it was really just a Nixonian.
Yeah, there was a political and ideological component to its suppression, clearly. So let's dive into magnetic brain stimulation. How has your work in that field evolved? How has the treatment itself evolved? What has the treatment potentially revealed about the pathophysiology of depression?
When we started working on what we call SANE, or Stanford Accelerated Intelligent Neuromodulation Therapy, this rapid acting TMS approach, we focused on this idea that we should we should kind of merge the best aspects of both technologies. So can we take TMS and reorganize it in time to be able to stimulate in a way that looks a lot more like how an implanted device stimulates? So something that looks like all day stimulation. And then can we, just like with implanted technology, can we end up focusing much more specifically on a given brain network, instead of how the old TMS approach works, where you were kind of zooming in at the level of like the skull landmarks, which is, as you know, you're going into a different brain circuit every time. And then can we give a dose that is a dose escalation sort of approach that's similar to the way that we deal with drugs, escalate the dose, really try to figure out, is there toxicity at certain doses, and give folks enough to be able to have a kind of a dose response curve. And what ended up happening was that we were able to observe a lot more proportion of people going in and getting well with the with this sort of really dense, focused approach, high dose approach. And what's useful about that is now we're trying to develop an implanted device that can do this chronically. And it's not a neuroscience question, it's just an engineering question. If we can get somebody, we can treat them with a non-invasive approach and get them well, but they can't hold it. They get well, but in a couple of weeks they lose it, but they reproducibly get well. If you give them more dose, they'll kind of continue to stay well for longer. Then that tells you that you just need something that's going to emulate that's a chronic indwelling device. And that's really the way that I've thought about it, as building this platform. And then, maybe there's some people that don't do well, and you build feedback loops into the platform that tell you, oh, well, you need to do this or that to get the folks better. Then more recently, to your question about, the underlying neurophysiology, one of my and Carl Dijksterhoff's postdocs, this guy Anish Mitra, been working with Marcus Rakel in WashU for his MD PhD, and then he came to do residency with us. He took his approaches that he developed in kind of basic and translational neuroscience with human brains, looking at normal healthy controls, looking at split brain patients, and looking at epilepsy patients that had ECOG. And he figured out that, not only on the kind of electrophysiology, but even on the brain scan, if you look at something called the time series of the bold fluctuation, right? So these nodes and brain networks that are connected, what you can see is that there's a temporal offset between one brain network and another.
I think he talked about this on the Andrew Huberman podcast.
Yeah, exactly. Yeah. And so the temporal offset in normal healthy controls is that the dorsolateral prefrontal and the anterior insula end up preceding temporally the cingulate.
So they're activated before the cingulate.
Yeah, and they may govern the cingulate, right? They may have a causal role in regulating the cingulate. In depression, the cingulate this is some of the novelty that he found, precedes the DLPFC and the anterior insula. Not in everybody, but in some patients. And in those some patients, those are the people that respond to SAINT, and those are the people that flip it post-treatment. The people that don't have it don't really move clinically and don't have the biomarker change, or they don't have it at all, right? And so it's this idea that you really need, we may be able to in the future, if this is real and we do bigger studies and we continue to see it and all that good stuff, you may be able to sort people by an MRI before ever treating them. Which, if you could do that, this would be the first time, in neuroscience that you're able to do that, where you're able to pick out, a biomarker that seems to change, be predictive and change over time. And I think that would be huge, right? We'd be able to kind of move the ball forward in that way. And it would look a lot more like the rest of medicine. As you know, right? You got your primary care doctor, you have 10 patients that come in and they have polyuria, polydipsia, headache, that sort of, right? Not all of them have diabetes.
Yes. The presentation just happens to be similar.
Yeah, the presentation just happens to be similar, right? They may have something else. They may have migraine headache, and they may have, whatever, some other kidney problem or something that's driving some of this, right? But their presentation is the same. And it's very likely, as you know, right? It's very likely that psychiatry has a lot of this lumping instead of splitting. But we don't know where to split, right?
So depression might be a common outcome between 5 or so disorders, which we're starting to understand and delineate. And what you're indicating is that based on this work, there might be one subtype of depression potentially where one of the characteristics of the subtype is that the anterior cingulate cortex is coming online before the dorsolateral prefrontal cortex can regulate it. And what the Stanford neuromodulation therapy can do is actually reverse that to make sure that the prefrontal cortex is actually regulating the anterior cingulate.
That's right. Yeah, and I think, and some people look at that and they say, well, that's really bad for me because if I don't have that thing, right? But But the reality is, from my perspective, it's actually good for both parties, right? Because it helps if we can split off one group and adequately treat them and figure out how to handle them, then we have a contrast point for the other group. Like, what is it about the other group that's going on in their brain? What about the other group? And then, you
And people
know,
aren't going to waste their time getting a treatment which we know won't work for them.
that's right. That's right. Yeah. When I was a neurology resident, I presented a very simple poster to the American Academy of Neurology back, I don't know, it was like 10 years ago or something, where they did these, DTI studies, diffusion tensor imaging studies. They look at the corticospinal tract, the area that comes out of the brain that controls motor movement, and they ended up observing folks that had complete severing of the corticospinal tract. Physical therapy didn't help them. They didn't regain any motor improvements. And it makes total sense, right? If you have nothing to work off of, then physical therapy is not going to do anything. If you've got this like little residual track left, then physical therapy can help you because you can build off of that little track, right? And I think that that's the same sort of situation here, right? Like, we need to be able to discern folks that have abnormality 1 and compare them to abnormality 2. And if abnormality 1 predicts saint response, it's a bigger question of does the absence of abnormality 1, for instance, predict people are going to respond to psychedelics or SSRIs or psychotherapy, or is it more of a content-based thing? I mean, these are the sorts of questions that I think we have to be able to answer. And the only way we can do it is to get one subgroup to compare to. And that's true for, if you look at the history of epilepsy, right? This is totally true. Like, if you look at, like, for instance, some anti-epileptics treat, most people have with epilepsy have the end result at times of generalized seizures, right? But some people have what we call complex partial seizures. Some people have primary generalized seizures. The neurologists have renamed these to new terms, but these are the old terms that everybody know. Generalized seizures, focal seizures, or partial seizures, or however you want to think about it. There are some drugs that if you give, that's designed for a generalized seizure, if you give it to somebody with a partial seizure, their partial seizures could get worse, and vice versa, right? But until we had the EEG, everybody was just having seizures, right? And we just didn't have any idea of how to.
You're limited by your conceptual categories.
Yeah, you're limited by those conceptual categories. And before that, people thought it may even be psychiatric, right? And so this idea that having a test to discern one from another is hugely important, because then it gives us categories, and it gives us the ability to kind of mold treatments based off those categories, and take a bunch of people with depression and separate them, and then look at their treatment responses to things. Hugely important, and so that's going to be, if making new treatments is important for the field, making these sorts of things is maybe even more important. And what's useful about neuromodulation is it gives us the ability to have a probe. TMS and SANE are not just treatments, right? They're probes of neural circuitry, right?
They're telling you something about how different parts of the brain relate to each other.
That's right. That's right. I mean, what we're doing, if this is true, what Anish found, what we're doing is that TMS is reversing a temporal abnormality. It's reversing an order of things.
Is there a sense of what the anterior cingulate cortex and the dorsolateral prefrontal cortex do, and therefore how they translate into depressive symptoms when the cingulate activates before the dorsolateral prefrontal cortex?
There's a lot of work around this idea that DLPFC and cingulate have this conflict role, right? And it if you look at the work that's been done, there are a bunch of great Science and Nature papers on this from like the early fMRI work in 2000. right? And actually some work that David Spiegel probably talked to you about, where you can actually hypnotize people, have different sorts of cognitions during conflict tasks, right? He and I have a study coming out where we've modulated hypnotizability with TMS, which I talk again with you later on once that's out. But essentially this idea that these two systems regulate conflict, and there's all sorts of conflict, right? There's completely cognitive conflict. I may not have much of an emotional reaction if I'm trying to make a decision about, do I turn left or do I turn right, right? And there may be certain conflict issues there. The Stroop task is a great example of something that picks up on this conflict, right? And so if you show people the word red in the color red, and you have them tell you what the color of the word is, pretty straightforward to do. You show the word blue and red, or the word red and blue, and you ask them to name the color of the word, it gets more complicated because you're talking about a conflict, right? And the DLPFC, and you put somebody in the scanner for that, the DLPFC and the cingulate kind of engage during that whole process. If you take a suicidal person and you have them do the Stroop test, they have a harder time doing it, right? Because they have a harder time regulating conflict. Hence why, you can actually have somebody end up trying to, or ending their life, because that system seems to be more dysfunctional, right?
So the brain has less of an ability to regulate itself in times of conflict, which could have a purely cognitive nature, but could have a strong emotional nature. Like, I'm stuck in a situation, because a lot of psychological suffering is born of conflict. Like,
That's right.
I want to finish my dissertation, but I'm struggling, and it results in procrastination. This is a conflict.
Yeah.
And without the brain's ability to sort through and regulate that conflict, you end up stuck and stagnating. And you can see if that was exaggerated to every facet of your life, if every facet of your life was a immovable conflict, how that could result in a depressive presentation or a suicidal presentation. Is that the idea?
That's right. Yeah. And the idea that, essentially we do, we in normal cognition, our dorsolateral prefrontal, our cognitive control networks, really kind of clamping down on conflict and saying, yeah, this is, that happened, but it's going to be okay. But and it's kind of like the prison warden and the prisoner, right? The prisoner is the cingulate in normal cognition. The prison warden is in control of the thing, right? Or how, whatever analogy you want to use, right? But
like player coach, the DLPFC is the coach and the cingulate is the player.
Yeah. The parent, the child, player, the coach, somewhere where like it's clear what the hierarchy should be, and then in depression, it's like the opposite is in control, right? I mean, I could imagine, if my 3-year-old daughter was making decisions about where to drive and where to, like, how that would all go, right? Or whatever, right? You've got the cingulate now making decisions about, being causally, having a causal role in DLPFC insula function in these severe depressives. And of course, in that situation, you've got a scenario where people aren't making good decisions. People have suicidal thoughts. People try to kill themselves. People try to, all of that makes total sense in the bigger context that this other system is working, and I think that's really where the problem ends up lying, right?
It's the ongoing pain of these seemingly immovable, unshakable conflicts.
Yeah, that's right. I think that's it. And then TMS just seems to temporarily reverse that, and then folks are kind of in control. And so I think that's the that's kind of the game plan from my standpoint is, how do we kind of get deeper into understanding what that is, get deeper into understanding what that neurophysiology is. It's going to take more invasive work. That's why, some of the implanted saint stuff is useful. We're going to be able to get, brain recordings to try to understand this more, similar to how we thought about EEG for epilepsy and how that really transitioned it. But that's really how we have to kind of move forward if we're going to really actually have a fundamental physiologic understanding of these problems.
Mm-hmm. So what does the Stanford neuromodulation therapy look like from the patient's point of view? What's happening? How long does it take?
Yeah, so they come in, they get evaluated. In the case of studies, and even probably clinical rollout, they're going to get evaluated in week 1. We do it on like Friday, and they come in on Monday, a little before 8. We get them registered, and then they're in the chair for 9 minutes, and then they have a break. So for some people, that break means sleep. For some people, that break means, trying to do tasks or whatever. For some people, they're trying to meditate, that sort of thing. As the week goes on, if people are getting better, then that break means that they're kind of progressively getting better over that time period, and then they end up with a capacity. For some people, they're we get out there on Thursday or Friday when they're feeling well, they're holding like conference calls and all sorts of stuff in between those breaks.
How many 9-minute sessions are they having per day?
10. So it's about 90 minutes spread out over 10 hours a day, and then they do that for 5 days. And a lot of people told me nobody would do this, but if you look at all the old TMS kind of thing, if you look at old TMS, it's kind of a pain in the butt. You've got to leave your job. You probably have to tell your boss you're leaving your job. You have to, when you leave your job, you have to kind of cut out early, drive over there, do your one treatment, and drive home or drive back to work or whatever. This lets you kind of get it done in a vacation week and just be done with the whole thing, and so it's, people see it as much more convenient. I mean, it is a lot of time in the chair, but they see it as more convenient, ultimately. Yeah.
And has the work currently been carried out on patients who have treatment-resistant depression?
Yeah, and actually, I was thrilled to get this invite because we use this Maudsley staging method as our primary way of sorting people. And we, for the trials, we only take moderate to severe folks because we're looking for kind of the sickest of the sick. But in clinical practice, all treatment resistant patients that have failed at least one med will have this available to them, at least in the US.
Yes, I'm currently working for the National Affective Disorders Service. So I'm literally working for our service.
Oh, cool.
That does work on patients with treatment-resistant depression. And as part of our service, we've got a ketamine clinic, we've got DBS, and we've got TMS. So a lot of my immediate colleagues at the moment would be very interested in this conversation.
Yeah, and I think, happy to talk offline about that. I mean, I think, there's a company that spun out called Magnus Medical that's commercializing this, and I'm happy to make intros to folks. So some of my students went over there at work, and essentially they're just very passionate about trying to get this out and actually figure out a way to get it reimbursed and get it covered in other countries and all that good stuff. And I think, it's a useful in between normal TMS and ECT as far as something that's going to be kind of in a higher acuity setting. Yeah.
Are there any side effects that patients tend to experience from this treatment?
Yeah, so you've got the theoretical risk of seizure. We've never had a seizure, but normal TMS has a seizure risk. Then you've got you get the side effects that we observed in the trials, which is Tylenol responsive headache, and then everything else was not statistically significant, so fatigue, but both groups got fatigue. It's just from being there all week and things like that. So it's really just some people get headache, and it's Tylenol responsive, and that's really it. It's pretty safe.
And what do patients report subjectively that happens when they get better, when they make improvements?
It's interesting. So the first thing that happens is folks end up, I'll go to them and I'll say, hey, when's the last time you thought about ending your life, right? And they always have this confused look on their face because they hadn't thought about it for 2-3 days, and they'd lost the SI and they hadn't kind of realized they lost it. And so then they realized they hadn't thought about ending their life in a couple of days. And then, we're finding that things like lassitude, go faster. And then sadness is kind of the last thing that people say that they lose. they lose the sadness last, but they look really good and their family's saying they look good.
A bit like antidepressants. That's classic. What we learned about antidepressants is they tend to improve objectively to outsiders before they feel a subjective improvement in mood.
Yeah, that's right. Yeah, I mean, I think the difference is the SI goes first before any of that other stuff, whereas, as you know, like that's less typical for an oral antidepressant to kind of have the SI go first. But yeah, from after the SI on, and when we see that with TMS2 and ECT, right, it's this idea that you see that the family sees a change first and the person is the last one to kind of fully observe it. And so, we typically tend to see people Wednesday, Thursday, Friday tell us that the sadness is gone and they're truly feeling better.
And I think you've talked before about how you've observed patients not merely feeling better, but also their outlook on the world is more flexible and they see solutions more where previously they weren't able to see solutions. They're able to think more strategically about their situation.
Yeah, I mean, people are just generally cognitively more flexible about how they're approaching the world, and the things that they saw as being like a barrier aren't a barrier anymore. They're not a definitive roadblock. It's more of a flexible, situation for them.
And how long do these effects seem to last after? So they have a 5-day treatment. How long does that tend to last?
Yeah, it's variable. There's some people years, some people months, some people weeks. And it's just.
I mean,
it's
what percentage show an improvement? And then all of the percentage that's shown improvement, how long does that tend to last?
Yeah, we're doing that study now, so we'll have a good sense of it. The problem is that we didn't follow people long enough for me to give you like a definitive number. I can tell you that our first person in the RCT, I called him to do some of the TV stuff we had. He didn't want to do it, but when I talked to him, he said, "Yeah, I'm still well." And it was like 4 or 5 years later, And so there's some people that will get a week and then they'll be well forever. There's some people that get a week and then, particularly people that failed ECT and whatnot, it doesn't last but a few weeks. So it really just depends. What we know is that if you get retreated over time, that you can actually get a better outcome, durability wise, from just kind of the same with ECT, just maintenance treatments. You can keep anybody that gets well, keep them staying well for a extended period of time. And we observed that with some trials, that kind of unpublished trials. And so, but the frequency is different with everybody, right? Like the number of treatments needed to keep people well, but there's no real evidence of tachyphylaxis or tolerance, right? Which are important distinctions from ketamine and esketamine, where it's pretty clear that there's for some people a tachyphylaxis, a tolerance that builds up over time.
So shifting over more to psychedelics, one thing, psychedelics are obviously becoming increasingly popular. And one thing I wanted to ask you about is, what is our knowledge about how psychedelics affect the brain, and this distinction between, is it the biological effect that these substances are having on the brain that's beneficial, or is it the actual having of a psychedelic experience that's beneficial? And maybe if we could start with a conventional psychedelic like psilocybin, say, and then move on to other related substances.
Yeah, it's a great question. I mean, what's going on right now is there's a number of individuals that are chemists that are out there trying to modify the molecules to take the psychedelic effect away, to take various unwanted side effects away. The problem with that, if the drug works, that'll be fine. If the drug doesn't work, then it doesn't tell you anything, right?
Mm-hmm.
Because you kind of made two moves. You've taken the thing away and you've taken the molecule's innate chemical structure, and they may be phenomenon that are co-occurring in time, but you need that molecule independent of the psychological effect, right? So we saw that with our ketamine naltrexone trial. We demonstrated that it's the first trial in humans to ever kind of really show us a kind of a mechanism for, we can, some people are lumpers, some people are splitters about whether or not ketamine is truly psychedelic. People call it dissociative anesthetic. But for the purposes of this conversation, let's say that there is a psychedelic experience that some people can have with ketamine. If you think about ketamine is lumped into this rapid acting psychoactive drug group, it's the first time anybody in humans has been able to discern a mechanism, right? We were able to, with naltrexone, knock out the antidepressant effect without having an effect on the dissociation. So it's my view that the psychedelic effect is probably, necessary but not sufficient. That's what I personally believe. I don't have enough evidence to support that, but what that evidence tells us is not sufficient, right? It's not sufficient in and of itself. Those folks had a very similar psychoactive effect with the naltrexone on board, and they did not have an antidepressant effect. So there are some people who are in the camp. There's kind of three camps, right? Not two. There's the camp where the psychological effect is all that matters, and I don't believe that.
Mm-hmm.
There's a camp where the psychological effect doesn't matter, and I don't believe that either.
Mm-hmm.
But there's this camp where it's like you really need the chemistry and the psychological effect, and that together is what matters. And that's the camp I'm in, where you really need the actual biology to be happening, and you need the kind of subjective experience.
They're inseparable.
Yeah, and the only way to figure that out is some work the only way I've thought to figure it out is some work that I'm doing with a guy by the name of Rag Aaron, who's a radiologist at Stanford, and he's got a method where he's able to package drug into nanoparticle cages and then use ultrasound to release those nanoparticle cages, into brain regions, right? So you have these nanoparticles circulating around, they release. In this case, we're going to use ketamine in the cingulate for pain as a first try, just because it's more measurable in kind of the acute moment. And then you measure pain, in this case, pain changes. And then if you are able to have an antinociceptive effect without having a dissociative effect, then you can start unraveling this, because you're putting the same drug, but you're just putting it in one brain region instead of putting it in the whole brain. And so then you're not modifying the drug.
You're modifying the location where it's being applied.
That's right. You're isolating it into a given brain region, and that may or may not be the best experiment, but it is a good starting point. But you could do this with psilocybin, right? You could go through and you could put psilocybin in the cingulate, and just subgenual cingulate, just in the dorsolateral, just in the insula, just in this, just in that, and you could start to map psilocybin effects, antidepressant effects, psychedelic effects, right? And your biological neuroimaging based effects or whatever. And do you get one without the others with the same compound? And then I think you'd be able to have a separable sort of story, because you're maintaining the integrity of the drug. These guys that are modifying these psychedelic structures, they're just hoping for a win. But if they don't get a win, not going to really tell us that much. It'll tell us that particular non-natural substance, non-normally explored drug doesn't have an antidepressant effect or whatever, but it won't tell us anything else, I don't think, and I think that's the limitation of those other approaches. And so, these kind of focal approaches may be the way to go. There may be other ways to do it, but there's a lot of work to be done to really understand the psychedelic effects. And I think it's a much harder game. The psychedelic game as and we're doing both. We're doing psychedelic studies, we're doing neuromodulation studies. The psychedelic study game to get an answer is going to be a much longer time course, because of the nature of how it's applied.
Because they have so many effects on the brain, whereas stimulation is a very precise intervention.
Yeah, that's right. Yeah, I mean, taking an oral psychedelic or even a normal IV psychedelic, you just it's an open-ended question, like, what is this doing? I mean, I was invited to a GI conference to talk about the brain gut interactions of psychedelics, and this whole idea that as most of serotonin receptors is in the gut, out of the brain, right? So I mean, what is it that we're doing, and they're asking me, could you treat IBS with psychedelics or whatever, you know what I mean? So it's one of these things where, it's just it's a real open question as far as like what what the game plan ends up being as far as how to solve that. Whereas brain stimulation, like, there probably are downstream vagal effects. We've seen that. We have data that you can slow the heart, you can accelerate the heart rate with TMS, but the directionality is very clear.
Yeah.
It's extremely unlikely, probably impossible, that stimulation effects are happening in the gut. Like, if you got the coil in the brain, they're happening in the gut and then going up to the brain. But with psychedelics, we have no idea. Are you doing some of the gut, it's going to the brain? Are you doing some of the brain, it's going to the gut, or whatever, and then it's in the whole brain, not just in in one brain region. And so we've got a lot of work to do, and it's going to be a harder road. My suspicion is that, and people are in, most of the neuromodulation people are in the neuromodulation camp. Most of the psychedelic people are in the psychedelic camp. There are very few of us, myself, this guy Greg Fonzo, and UT Austin, a few others that I know, where it's like, yeah, the future probably is both of these, kind of forward movements in psychiatry. Like, if you really look at psychiatry, like, what are the two camps of where people think the future of psychiatry is, right? It's a neuromodulation camp, there's a psychedelic camp, and then I don't know, there's this other camp that doesn't know, or whatever, but these are the two main forward thrusts, as you know.
It's interesting how people fall into camps, and I usually default to personality as the dominant reason why someone might fall into one camp or another, because you see how something like stimulation, a very medical, precise treatment, might appeal to one kind of physician or clinician or researcher, whereas something like psychedelics might appeal to someone. Really, I'm thinking of people who are high in trait openness, who are
Yeah.
It's really compels people who are fascinated by the experience that you have, and the diverse range of experience that one can have on a psychedelic. Is there irrelevant of what we think is actually doing the therapeutic heavy lifting? What do we know that's important about how, for example, psilocybin affects the brain when it's ingested? Are there a few headline changes that are worth mentioning?
Yeah, I mean, Robin Carhart Harris has done most of this work, others out there, but for psilocybin, he's been, the first person that's really done a lot of the neuroimaging, him and Dave Nutt, when he was at Imperial, and then now he's at UCSF, right? And so it's this idea of, there's kind of three things that seem to be happening. The first one is, brain activity seems to go down, right? Which is the opposite of what they anticipated. They thought brain activity would go up. Brain activity goes down, which is really curious and probably the most weird thing, right? Because it tells you that it's like, most people think that these subjective experiences are constructs of the drug, and that argues way against that, right? That it's really, that if the brain activity is going down, that it's really more that we're gating a lot of information, right, to the thalamus probably. The second thing is that the kind of global level of connectivity in the brain goes up, right? So the brain activity goes down, the connectivity goes up. And then specifically, if you're looking at like its antidepressant effects, this is where TMS and really insane, what we've seen in psilocybin seem to mechanistically kind of align, which is that there's a default mode subgenual connectivity decrease. So not just us, but multiple people, Connor Liston and others, have demonstrated a DMN subgenual connectivity decrease. And that's definitely also happening with psilocybin from Robin's work, right? And so
it's known, I think, that mindfulness meditation can decrease activity in the default mode network as well. Is that right?
Yeah, that's right. Yeah. And so this idea that you're uncoupling the self-representation, the default mode network, with, in this case, the sadness area, the subgenual cingulate, is useful and instructive, right? So,
and then how does that differ from, so my understanding is you're studying a psychedelic called ibogaine, which really isn't talked about at all. What are the differences between psilocybin and ibogaine?
Ibogaine is a much broader acting psychedelic. It hits many more systems than, just the kind of primarily 5-HT2A, agonism that happens with psilocybin and the classic psychedelics. It has a role with, some of the same things that ketamine does with the NMDA system. It has effects on the opiate system. It also does something that none of the other drugs do, which is it at scale, which is that it upregulates glial-derived neurotrophic factor. The trip or the sense, the kind of experience is very different, right? People describe it as an open eye, normal experience and closed eye, kind of rehashing of past life events. People go into this kind of dream-like state. People call it a neurogen. And so, it has a kind of a different sort of effect. It's definitely still psychedelic, but people think about it more as like a typical psychedelic because it's not, that classic serotonergic sort of thing. Very interesting. We're studying this in veterans and Navy SEALs and special operators, and we'll have a paper out soon, and then I'll talk about the outcomes when that fully comes out. Yeah.
Amazing. And is there some notion, maybe from some anecdotal data you have, that the ibogaine trip allows people to interact with their psychology in a way that they're not normally able to?
Yeah, I mean, I think with all of them, right, it puts people in a different kind of circuit set that when they approach the symptoms, they're not as how they describe it with MDMA is like folks with PTSD, they're either like overactivated or underactivated, but they're not able to actually like deal with the content. You hear that same sort of thing with ibogaine, where like people either kind of are like shunning it or they're like in the middle of it and they're having a crisis and they can't deal with it. And what a lot of the psychedelics end up doing is putting you into this middle ground where you're able to actually look at it, but you're not in fight or flight mode,
The window of tolerance, we call it in psychotherapy.
Yeah, exactly. Yeah. So this idea that you're really able to, yeah, tolerate that level of anxiety and work with it. And I think the psychedelic drugs uniquely allow for folks to do that. And MDMA, which is really an empathogen, kind of specifically seems to be really good when it comes to trauma for that. Yeah.
Because MDMA decreases activity in the amygdala, is that right?
Yeah. It reduces cue-induced trauma, like trauma cue-induced reactivity in the amygdala.
Well, Dr. Williams, it's been wonderful talking to you. I'm conscious of your time. But just before we wrap up, one question I like to ask clinicians, one of the privileges of psychiatry is we get to interact with people and learn about their past and hopefully gear them towards a better future. And in doing so, we get to interact with human nature and think about human nature. So my last question is, what has surprised you the most about human nature as you've progressed through your work?
You can have somebody 70% better from depression, and everybody, their family, our assessment team, like everybody is looking at this person and they're just convinced they're no better or whatever, or something like that, people or alexithymic folks who just, they are totally better, and they're saying like, I don't feel sad anymore. And they still think they're depressed somehow, so there's all those sorts of phenomena, almost like neglect, like phenomenon that I think are so fascinating and so complicated to deal with, right? With patients who can't fully recognize kind of where, in this case, where their mood's at or whatever, and trying to kind of understand. And it's very hard, with somebody like that to even, convince them or try to talk to them. So you can't really, that's their kind of position on the whole thing or whatever. And so there's a lot of that. I think a lot of that sort of thing that happens with therapeutics, right? With folks getting better and all that good stuff, and what makes this such a hard specialty to kind of deal with because we don't have objective tests,
And I think that's something maybe getting back to the beginning of the conversation where we talked about neurology and psychiatry. If psychiatry can learn from neurology to be more brain-based, I think
Yeah,
what neurology can learn from psychiatry is all the soft skills, how to interact with people. And I think one of the biggest areas within that, how to gently deliver insights
that's right.
that patients need without overwhelming them, because people can be remarkably, as you pointed out, like not self-aware of different things. And you can't force insight on
That's right.
people wholesale. You need to kind of deliver it in these digestible formats and help people develop insights about themselves, help to facilitate that.
Yeah, absolutely. And that's definitely, I think, in the long-term psychotherapy relationship, as you're saying, that's definitely what it is. What ends up happening, I think, in these very high acuity, short kind of treatments, right, is that that's not baked into the whole experience, right? If you bring somebody in and you treat them on an inpatient unit and then they get discharged, you don't have the therapeutic relationship to do what you're saying, really. You don't have the time either, right? Like they're well, they're leaving, or they're, mostly well, or whatever it is, right? Like and to your point, right, we have to maximally integrate kind of on both sides those sorts of things, right? And be able to have a way of doing that. But I don't know, to be honest with you, it becomes kind of complicated when you don't have the biomarker there, right? Because the person goes back to the psychotherapist, depending upon that person's kind of understanding and knowledge of the patient. They may appreciate that, they may not appreciate that. They may not, if this is a new therapist for the patient, there's like no way they could even figure it out, you know what I mean? And then it just goes back again to the person's experience. If we all got on the same page and had we came to a place where we had a biomarker, we got on the same page that we all believed it, then it actually is very helpful for the therapist. It is very helpful for the psychiatrist seeing somebody long term to do that sort of thing, because then the psychiatrist or the therapist can be confident that they're pushing in the right direction, right? And right now it's like an open sea where we don't know where the right direction is. And I've been in that situation too, right? Do I trust somebody goes and gets ECT or whatever, do I trust the ECT doctor that they did get better and then they lost it or whatever? Do I trust the patient, then this never worked for them? And you hear that patients, it's very clear they got ECT, they got well for a while, they stopped wanting to do maintenance and they lost it and they went back to their normal state. The patient will tell you, like, yeah, I never got any better with that. I've heard that many times with patients getting ECT or whatever. And it's really about having, I think at the end of the day, having something so everybody gets on the same page. I think it equips the kind of long-term kind of therapist focused, practitioner to help with reinforcing and kind of guiding the person in the right direction. I'll tell you a funny story. I had a patient in our last trial who, our blind was like totally intact if you read the paper, right? And this is another really interesting phenomenon. So we had total blinding, which nobody predicted, including me. I thought there was no way we would have total blinding. But what I saw as the study went on, the people that got better, they were totally better. I remember this one guy, I saw him in the hall like on the last day, and I was like, I'm trying to not get unblinded or anything, but I'm just like, hey, how are you doing? What, how are you feeling? Oh, I feel amazing. Said, oh, well, like, what do you attribute that to? And he's like, placebo effect, right? And the guy's like a 0 on the MADRS or something. Like, he's like perfect. And then a month later, I see him in the hallway again, and he's back for his 1-month visit. And he says, he sees me and he says, the whole month my therapist has been trying to talk me into the fact that I probably got the real deal. But, I'm kind of like maybe or whatever. and we unblind the study later on and we go and look, and I was very curious about this guy in particular. And I was like, I wonder, what he was. And he totally got active, but he totally, like, in his head, because he'd been depressed for 30 years, he's like, it would be my luck that I'd get placebo effect now, even though he'd never had placebo effect ever before, right? And then we had a lot of folks who had the opposite, right? Where they didn't get better, and then they were depressed, and their depressive brain, they were like, I must have gotten the real thing, and this is just yet another failure for me, right? So they were totally blinded because the depression led the folks that didn't get better, they got sham, to think they got active, and then folks that been so chronic in the active group, they just thought they'd gotten lucky with sham.
It makes me think of what Freud referred to as like garden variety unhappiness. That once
Yep.
you lift heavy psychopathology, you're left with garden variety unhappiness.
Yeah, and that's not, I mean, the guy that I told you about a second ago, he literally was like a 1 or a 2 on the MADRS. He was not unhappy at all, but he just, and it wasn't like he was sad and said this. What he said, he just said, look, like, this must be placebo just because my history has been this way, right? But from like a mood standpoint, he was perfect. And it's more kind of the institutionalization of people thinking when they're in TRD that they're just going to be stuck in it forever or whatever. But it's this idea that, like, I think at the end of the day, if we had a biomarker, and that person thought he may have, because even with active treatment, known active treatment, people think it's placebo, right? The therapist would have been able to be like, look, you had this, it's gone. And we do this in neurology all the time. You had a stroke, you had a clot in this blood vessel, the interventionalists pull the clot out, it's gone. Yeah, you're having tingling in your hand, it's not from the stroke. You know what I mean?
Yes.
That's what we all need. We need the ability to be able to do that. And then we can, I think, maximally help people.
Yeah. To get people on board with these objective landmarks that we can use to anchor people in some kind of objective reality.
Well, to be able to tell people they've been that it's been, the problem's been fixed, right? Which I think is not something that we kind of historically tend to kind of think about or do in the case of psychiatry. And it's also I see it in neurology all the time. I see it all my neurology patients, they have all these symptoms, right? Like a lot of even epilepsy patients have psychogenic seizures too, right? And it's not just to your point, it's not just a psychiatry thing, right? It's not just a psychiatric illness thing. But when you show them, look, your EEG's been normal, your brain scan's now normal, then they can chill out. Right? It's like it gives them the ability to then go and say, okay, this is corrected, right? I don't have to worry about this anymore. And then some of the like stress-induced symptoms go down.
But
You know
then
what I mean?
to push back on that, neurology has a lot of patients who have these symptoms which don't have a clear explanation, and often normal tests aren't reassuring. And then I think then psychology can help us here, because it helps us maybe to understand that some people almost need the narrative of something being wrong. But this is a completely different set of people from people who actually have detectable issues with their neurobiology.
Yeah, I mean, I'd argue that, well, at least for us, right? We don't include people in trials that have been depressed since I was a baby or whatever, right? Like, we're looking for episodic illness with periods of euthymia. To your point, because there is a subgroup of people that may be their issue, and I agree with that point. But I also think that the absence of positive test findings with the right therapist can be helpful for those people, right? Because you can get them to a point. I've taken care of these non-epileptic seizure folks or psychogenic seizure folks, or however you want to think about it. And those folks, it takes a while. They need reassurance. They need to see the tests, but you can get them on board with the idea that their seizures, these spells they're having are really arising from a different place, kind of a different manifestation or different pathophysiology than than seizures. And there is a ton of work going on right now by neurologists and psychiatrists around understanding the basic neurophysiology of what we used to refer to as conversion disorder, or psychogenic, these phenomenon that seem to also arise from the conflict circuitry. And so I think that tests are good. Tests help us to discriminate things. They're not perfect, as you're pointing out. I agree with that, but on balance, having a test is going to help more people than it hurts. That's for sure.
Yeah, that makes perfect sense. Dr. Williams, it's been wonderful to speak to you. I look forward to following your work as it continues to progress, and we'll be glad to have you back at some point in the future.
Sounds great. Yeah, really appreciate this talk, and have a great day. Thank you so much.
Thanks so much for listening this week. If you've got any feedback, as always, do get in touch. If you enjoyed the episode, why not give us a rating on Spotify or Apple Podcasts, because it really helps other people to find us. If you want to get in touch, you can find us on Instagram or Twitter, or you can drop us an email. And if you value the show more generally, why not buy us a coffee just to help keep us going? Thanks so much.